I would like to introduce Don Klepser, a co-worker of mine. He, I think recently, and he'll maybe talk with you about it, did some work with PTCB for the point of care testing. And so very much, his specialty. And so please help me in welcoming Don.
Judy, thank you so much. Can you all hear me? All right. So I also recognize it is Friday at 5 o'clock, and there's probably nothing you want more than the last guy talking to wrap it up so that you can get to dinner or drinks or whatever it is you do on a Friday night. So I'm going to move through, certainly take any questions you might have. So Judy mentioned, so I've been doing work in the area of pharmacy-based point-of-care testing for 13 years. Really, it came out of the H1N1 influenza pandemic in 2009. So for those of you who remember that, that was a great tipping point for pharmacy in that it really is probably the catalyst for pharmacy-based immunization. Prior to that, there were things happening and there were pharmacies doing it, and you could go to a pharmacy and get a flu shot, but it was still probably more the exception than the rule. And certainly we all know what has happened in the past decade plus, right? Over 25%, and that's probably a dated number of flu shots are given in pharmacy every year. Certainly when we rolled around to COVID, there wasn't a question of whether or not pharmacy was going to be involved. The question was when and how and who. And certainly what we saw as we got into COVID vaccines was an expanded role for technicians, an expanded role for interns. And so all exciting times. I think there is a sense that COVID may have a similar impact on pharmacy-based testing. So, I mentioned that for 13 years, we have been doing work in this area, working with large chains, working with others to set up and develop influenza, strep, HIV, hepatitis C, Lyme disease, kind of you name it, testing programs in pharmacies. And it's been a slow process. And then COVID hits. Who had a COVID test at some point over the last 18 months? I would guess many, if not all of us have, had. How many of you had it at a pharmacy? A few of you, okay. Depending on where you live, and whether that means they collected the sample there and sent it off to a central lab, or they ran the test in the pharmacy itself. There was quite a bit of activity that really made this happen. So as part of this and in response to this, PTCB has recently decided that they were going to have, and I will admit it, I don't know all of the language and the requirements and the rules, but they're going to set up an exam around point of care testing, and I anticipate that comes out sometime in early fall. And they asked me to help write questions for that. ASHP, the American Society of Health Systems Pharmacy, then put together a program to prepare pharmacy technicians for that, and I had the pleasure of being involved in that as well. So lots of things happening, but I think it all kind of comes together with then the talk. So you all know your code of ethics. Very quickly in terms of learning objectives for today, I want to talk a little bit about how COVID-19 has impacted the regulatory and practice landscape for pharmacy-based point-of-care testing. And I don't want, if you listen really carefully, you might hear the Jaws music, just when you thought it was safe to go back in the water. I've spent my day as associate dean talking about, do we need to get back into masks? Do we need to set up, do we need to ramp up testing again? With this Delta variant, things are coming back. Find some wood to knock on. Hopefully it's a blip. Hopefully it's just, but it is not entirely behind us. But really what I want to focus on is how those changes impact the future of pharmacy-based point-of-care testing, and then really spend time for this audience talking about the role of the pharmacy technician. Because I will tell you 100% flat out, this does not happen without pharmacy technicians. This is, and so if you see my background or you've heard me speak before, you'll know I'm a health economist by training. So I always approach things from a business standpoint. How do we make this a sustainable service? You can't deliver great patient care for free, and we can't do this without technicians, right? We can't develop sustainable service without pharmacy technicians. So the question people asked, and particularly prior to COVID, was why would, look, we have central labs, we have Quest labs, I can go to my doctor's office, I can go and get tested other places, right? The healthcare system is there, it works. Why would we even think about expanding testing beyond those places? And so I will tell you part of it is, and to go back again to when we got into this in 2009, it's about access. We saw it this year. Did anybody try and schedule an appointment to get tested with their? First of all, if you called your primary care provider and said, "Hey, I'd like to come in and get tested for COVID. I can't smell," and they would have said, "Stay the bleep away, right? Do not come in. We do not want you here. Go to some drive-in testing place across town." If we had relied on primary care or emergency rooms or urgent care clinics, we would have been overwhelmed. And we were, right? I mean, there was a time when you couldn't get an appointment to get tested for days, and then the results took days. Well, with a disease like COVID or influenza or group A strep or that's not good enough, right? We need access to care now, right? We need walk-in or quick appointments with results in 30 minutes or less. For those of you who know, this is like the old Domino's pizza, right? It's delivered in 30 minutes or less, or it's free. And that's what we need when we're trying to slow down the spread of an infectious disease. It's not about 2 days and 4 days and we'll get you the results in a week. That's just not good enough. So first and foremost, it's about access to care. That's closely related to the quality of care. Early and reliable diagnosis, along with the potential to accurately monitor disease, has the potential to improve outcomes. I think anybody would tell you, one way to slow the spread of COVID or slow the spread of influenza is identify cases early. Even if there's not a treatment, let's get people to isolate. Let's get people to quarantine. Let's get people away from, where they're not spreading it to others. If there's a treatment, for example, like influenza, time to first dose matters. Right? And I don't know what you know about Tamiflu or any of the other treatments out there, but if you can get that first dose to people early, you can have the biggest impact on symptoms and spread of the disease. And then finally, cost of care. If somebody is going, right, if we have to utilize the emergency room for this, that is really inefficient. That is really a poor use of our resources, right? Let's keep emergency rooms for emergencies. Let's keep people out of there. But the truth is, for a lot of Americans, and I kind of sheepishly will raise my hand on this, who don't have primary care providers, your options are pretty limited, right? I don't have a physician. I don't have a primary care doctor. If I get sick, my options are ER, urgent care, ride it out. I just tend to choose that one, a good beer or bourbon on a weekend, that'll get you through most things, but not the greatest thing, not the greatest way to take care of yourself. So can we improve people's access? Can we give a more efficient, low-cost point of care where we can still receive high-quality care? And that's what this becomes about. So again, for 13 years, like the prophet out in the wilderness, preaching to the trees, things happen really slowly, right? I mean, I've had conversations with almost every state executive. I've had conversations with, every pharmacy chain CEO or second in command that you can think of, and everybody is, okay, I understand it, right? That makes some sense, but show me the value. Demonstrate the value to me of this. And so and you have to repeat that exercise with everybody. Oh yeah, it works great in Nebraska, but we're Iowa, we're so much different. Like your hat's black and our hat's red. That's about the only difference, right? I mean, it's still corn. But you have to walk through it. Why you're special. Right? The practice of pharmacy, like the practice of medicine, is state level, and so you have to go through state level, changes and regulatory changes, and it's just painfully slow. And I mean, look, I'll be very honest, there are barriers there to protect people's self-interest. I was on a call this morning having the same conversation with people, and right, new ideas get compared to the ideal. Well, if we let pharmacy do this, and pharmacy technicians, and I know it's a 1 in a million rare event, but it could happen and somebody could die. Yes, true. And the exact same thing could happen in the care settings where people are getting tested today. But nobody wants to, right? It's always going to be compared to the ideal, to the best case. And so, again, it's just slow and painful and arduous to get people to move and rethink things. I was on a call with the Florida Board of Pharmacy Tuesday, I guess it was, and a physician got on board and said, or on the line, and asked almost exactly these same questions about Lyme disease. Well, do pharmacists know how to treat Lyme disease? Do pharmacists know anything? Yes. And now you have to show them and you have to demonstrate. And so it happens slowly. So, and this is terrible to say, but I've said it 100 times this year, so I'll say it one more. I haven't been struck by lightning yet. Let's not waste a good pandemic. Right? Because pandemics, for all the bad that goes along with a pandemic, one of the nice things is pandemics reduce barriers. Pandemics force people to focus on what's important. It forces people to focus on the goal. What are we really trying to achieve? When it comes down to COVID, and right, we just need to get people tested. As many people as we can get tested with high quality testing as fast as possible to get the results back as fast as possible. So all of a sudden, barriers that were previously insurmountable can be wiped away with a pen. And certainly some of that is what we saw this past year, or over the past 15 months. Things that I and others had been fighting against for a decade. The Assistant Secretary of Health comes out and says, you know what? Pharmacy can they can test everywhere. And all of a sudden, we see change. And so just a few numbers. So prior to COVID, about 16% of community pharmacies. So there's, give or take, let's say there are 60,000 community pharmacies in this country. That's independents, that's chains, that's big box retailers, grocery stores, and everything in between. About 60,000 of them. At the beginning of the pandemic, so early 2019, 10,000 of those were already operating as laboratories. So remember, if you're a pharmacy and you want to do point of care testing, you have to be a laboratory as well. It's not as simple as saying, hey, I think I'm going to do this. I mean, there are steps that you have to go through. You have to apply. You have to be recognized as a laboratory. So prior to that, 16%, 10,000 out of 60,000, about 16%, 17% of community pharmacies were operating as laboratories. I will tell you that varied incredibly from state to state. Anybody from Alaska? I would have bought you a beer. About 70% of pharmacies in Alaska were operating as labs. Anybody from New York? Okay. I would have made you buy me a beer. It would have still been cheaper than buying a beer in New York. Roughly this percent of pharmacies in New York were labs. 0. Because state law didn't allow it. The barriers were high. So most of these pharmacies, these 10,000 pharmacies that were operating as labs, are operating as CLIA waived labs, so doing simple testing, flu tests, strep tests, cholesterol screenings, the kinds of things that are simple, non-technical tests that the FDA has approved as waived. Right? From the FDA perspective, at the federal level, there is no training requirement involved in doing CLIA waive testing. Here are the steps, and I think I may have a slide on it, so I'm going to give it away early. Then you can put your head down and rest for a couple minutes. Right? You have to complete the application. You have to pay the fee. I think it's $150 for 2 years, and you have to agree to follow the manufacturer's instructions. That's it. That's the federal requirement for being a CLIA waived laboratory. You don't have to be a physician. You don't have to be a laboratorian. You don't have to have 57 years of college. You don't have to, right? You don't have to be able to stand on one leg and jump up and down and say the alphabet backwards, right? That's it. Follow the manufacturer's instructions. And manufacturers are required to make instructions so simple this guy can use them, right? These are like pictures, right? Put this up your nose and then put it into the tube and off you go. The states, however, that's the floor. States could raise that bar significantly if they chose, and some did. A lot of states said, you know what, federal requirements fine. State like Nebraska, there were no additional requirements. That's why our numbers were probably higher than the national average. But then there are states like New York, New Jersey, Nevada, others where they put barriers in place in terms of who could do the tests, what tests they could do, who could be the laboratory manager, could a pharmacy provide tests without a prescription from a prescriber, from a physician. All of those things have the effect of creating barriers. And then there are payment challenges. Do any of your pharmacies operate as charities? Right? You expect somebody to pay for the for the medications. You expect somebody to pay when they buy a candy bar or a greeting card or whatever. Right? Likewise, most of you would expect to be paid for offering a service like point-of-care testing. And in almost every other healthcare setting, that payment comes from an insurance company. Right? You go to the doctor's office. You go to the emergency room. You go wherever. You hand them your card, they tell you, hey, you owe us $10 or $50, whatever it is, copay, and your insurance will take care of the rest. Well, that's not the case in pharmacy settings. Right? Because the pharmacy is not recognized as a provider, you're asking somebody to pay entirely out of pocket. That's a barrier. That's a challenge, especially in some communities. So those are some of the barriers we saw. So what happened? On April 8th, 2020, and I've already alluded to this, the Office of the Assistant Secretary for Health issued guidance authorizing licensed pharmacists to order and administer COVID-19 tests, including the finger stick tests, the antibody tests, that the FDA had authorized for emergency use. Now, I put a little footnote down there. At that point, it didn't speak to reimbursement. So great news, pharmacy, you can go ahead and do all of the testing you want. There's no guarantee of payment. So it's like halfway there. Well, so what happened? Almost immediately, first of all, some states in the District of Columbia said, well, Office of the Assistant Secretary for Health, you didn't really mean that, did you? And so about a month later, he said, I really meant that. So states, you can't do anything to prohibit this, right? Quit being jerks, in effect. It was written more lawyerly, but that's kind of what it said. Quit being jerks, you have to allow this. But there was still then the payment barrier. There was still the issue about Medicare reimbursement. And so what happened almost within about a month after, somebody at CMS, Center for Medicare and Medicaid Services, said, wait, we can do something about this. We can provide a pathway to reimbursement for pharmacies. And what they did was said, you know what? Pharmacy, if you are a CLIA-waived laboratory, or if you want to be and are in the process, you can also submit as an independent diagnostic laboratory with CMS, and we will reimburse you. Not a huge amount of money. It's not like, this is, but there is reimbursement for the laboratory component. So under the CMS regulation, it used to be that diagnostic laboratory tests were only covered when ordered by a physician or other practitioner who uses it. So if the patient arrived at a pharmacy, they wouldn't cover the test. But there you go. In April 30th, so 22 days later, from the original guidance, it said pharmacists are considered providers, and those operating under a pharmacist are able to conduct. And why? Because all of those things that I talked about 4 slides ago, they recognize the importance of access to care. They recognize the need to expand our testing capabilities. They recognized the need to provide patients with alternative sources of care. And they recognize that if you have to go to a physician first, that's a barrier. And that's going to slow down testing. That's going to slow down patient access to care. So then about 9 days later, then they come out with the CMS guidance that said, not only can pharmacy order tests, provide tests, they will get reimbursed for tests. So pharmacies enrolled in Medicare and with a certificate of waiver can temporarily enroll as independent clinical labs. It's a big deal. I mean, it hasn't been recognized officially as a federal holiday yet, but I'm working on it, right? This is a big deal for pharmacy, because this is, I don't know what you follow in, but there is a lot of move to get pharmacists recognized as providers. This kind of was an end run to allow pharmacists and pharmacies and pharmacy technicians and interns and students to provide a service and get reimbursed for it directly from Medicare. That's big, right? Because then everybody else comes along. So what does it mean? Right? That's great. And by the time, we got around to, let's say, December, November of last year, we saw a huge uptick in the number of pharmacies operating as labs. We saw a whole bunch of pharmacies doing this. There were still challenges to get testing. There were still challenges to set up and operationalize. Obviously, pharmacies, just like anybody else, were a little hesitant to have a whole bunch of sick people coming in to the pharmacy. But you have drive-thrus and you have other mechanisms, and there are ways to do this. And then, of course, just as it's all getting rolling, the COVID vaccine comes out and everybody's focus goes from here, boom, over here. And so, where do we stand? So these barriers have been reduced or removed. The question is, for how long? And for what else? If it's just about removing a barrier to allow for testing during a pandemic, that's great during the pandemic. But it's not necessarily great for patient care. And I will also tell you we did about 1/10 as much as we could have done during the pandemic if we had been set up before the pandemic. Trying to stay, I don't know how your pharmacies were, the last 15 months. Most that I talked with that went into were over their heads, right? In terms of things that they were trying to do and trying to keep people safe and all of these things. And then trying to layer on that, getting set up as a ClearWave lab, finding testing supplies, PPE, going through the billing process was overwhelming. So in the middle of a crisis, we created about 5 more crises. How much better if we had been stood up and operating? So I will admit I have friends in the diagnostic testing industry, and they were overwhelmed with people saying, "Hey, can you get me these tests? Can you get me these things?" And they were like, "Remember when I called you 2 years ago?" And you're like, Well, if you had the kit now, the test back then, this would have been easy. So, right, there's an uptick in demand for pharmacist and technician training. And I will say this, has anybody ever done a point of care test? Has anybody ever collected a swab? Nasal swab? I've got a whole bunch in my office. If you guys are looking for fun later tonight, I can go get them. Right? It's not that hard. It's a skill. It's something you have to practice, but it's not that difficult. But you need to be trained, right? There should be some training around this. And so what we're seeing is, NASPA, the National Alliance of State Pharmacy Associations, has a certificate program. We're seeing colleges, pharmacy chains, wholesalers, and others holding trainings to meet this. Judy mentioned this, and I mentioned it as well. PTCB is developing a point-of-care testing exam for technicians. ASHP is developing a training program for technicians. So there is going to be, over the next 6 to 9 months, a real upswing in terms of training to get people to that comfort level. And again, some of it's skill, some of it's some paperwork requirements, some making sure you know what to do in terms of running a laboratory, but a lot of it is just, practice, right? And having an opportunity and knowing what to do, not necessarily how to do it. None of it is rocket science. So what have we seen? I think I mentioned in, pre-COVID, there was about 16%, 17, 18% of pharmacies, and we've seen that go up by over 10% just this past year. As a result of that reduction in barriers and pharmacies rushing in to fill that need. And I think that's, for me, one of the things I'm most proud of about being associated with the pharmacy profession and pharmacies in general is how willing pharmacies and pharmacists and pharmacy technicians and interns are to step up when asked. Right? I mean, and Judy knows this as well as I do. Last March and April, all of the other professions were saying, "Oh, I don't know. I'm not sure if our students are going to continue to go into our clinical sites. We don't want." And our students are like, "We're just going to work. This is our job. This is what we're signed on to do. This is our training. We're going to go in. We'll take appropriate precautions, but we will step in and do what we're asked to do." And I think that's, to me, the amazing thing, and I think this graph is indicative of that. When given that opportunity, 5,000 pharmacies, at a time when it would have been easy to say, "You know what, we're too busy doing other things," stepped up and said, "Hey, we'll start doing testing." Almost 10% of pharmacies across the country in a pandemic said, "Yeah, we'll play." So, we now have seen widespread adoption to the point where, so I'm on a call today with kind of the chancellor and campus-wide, and we're talking about, okay, what are we going to do for testing in the fall? And their stock response is, well, they'll just go to pharmacies. I'm like, they will? That's awesome. I hope the pharmacies know that, but that's cool. But again, we've quickly moved from, oh, can they, to, oh, that's what they do. And that's the expectation. Now, some of it will be, again, collecting and sending off. But, we see pharmacies doing antigen testing. We see pharmacies doing PCR testing. We see pharmacies doing antibody testing. Words that most of us were not even in our vocabulary a year ago, but now go and ask Grandma, and she even knows what all of these things are, right? And that's become kind of commonplace. So we've seen this huge upswing in knowledge about testing in general, certainly as it relates to COVID testing, but a lot of that same terminology, a lot of those same things carry over into other testing. One of the things that, I don't know if I'm excited about it or, large chains, everybody who ever comes to me and says, Don, we want to start doing, we want to get pharmacy using our tests. Can you get us an appointment with Walgreens or CVS? And I always say, why? Right? I mean, they're big. I get it. You want all 9,000 pharmacies. You want to flip the switch and be doing great things. That's not how they operate generally. I mean, they're big corporations. There's 57 levels, right? So, but amazingly, in COVID, whether we're talking about testing or we're talking about vaccinations, they stepped up and moved. Now, did they do it the way I would have done it? Maybe not. But still, the fact that they were visible, that they were out front, helped to move that dial, right? Helped to raise awareness, right? So it becomes highly visible. Now, everybody's doing it, and again, there are a lot of ways to get after this. There are a lot of different ways, whether it's rapid testing or specimen collection and send out, whether it's using a drive-through, if it's a public health partnership. All of these are still pharmacy-based testing. I think long-term the answer is point-of-care testing, where the pharmacy collects and runs the test in-house. And certainly the demand outpaced the supply. So if we had been there. So the awareness has never been higher. We have this recognition of the value of time to results, right? Again, mainstream media was talking about sensitivity and specificity, things that I can't get my third-year pharmacy students to understand, suddenly was on like the nightly news every day, and we're all now experts in the characteristics of testing. So the role of pharmacy and pharmacy technicians and pharmacy in general were absolutely highlighted here. The old saying, strike while the iron is hot. I mean, the iron can't get hotter. This is as good as it's going to get. This opportunity will likely never present itself again. So what are the next steps? Right? It starts with, permanently changing regulation that allows for ordering and interpreting of tests in the pharmacy by the pharmacy staff, right? Not having to ask permission, not having to enter into a collaborative practice agreement, not having to get somebody else to do that. Lowering barriers to test and treat. My hope is, we're going to have a reliable treatment for COVID at some point. We already do for influenza and certainly things like Group A strep. So testing is awesome, but the ability to test and treat immediately with appropriate prescription drugs, that's next level, right? That's when the game changes. That's when we can really and truly, tamp down pandemics before they start. And so getting to a point there. And that's the idea of this independent prescriptive authority. Anybody from Idaho? Is everybody from Nebraska? Before I just ask, okay, there's a couple of head shakes, all right, right? So there are states, Idaho, and here's a sentence that has almost never been uttered. Idaho is very progressive on this. Right? The state of Idaho is really kind of led the nation in terms of prescriptive authority for pharmacists. So there, in the state of Idaho and slowly now in other states, there are a number of minor ailments and conditions where pharmacists don't need to enter into a collaborative practice agreement with a physician. In other words, they don't need to get anybody's permission. It's within their training. It's within their scope of practice. They can do this. So anybody walks into any pharmacy in Idaho, if they choose to offer the service, they can test and treat on site. That's pretty impressive, right? So our practical advances, we've raised awareness, we've demonstrated the value, and now it's about delivering consistent, high-quality service. So the next step, the challenges, is moving this on to include other tests, right? COVID is the pandemic, but there's nothing particularly special about it in terms of patient care. There are a lot of other diseases with much, much better, actually, point-of-care tests where the results can be acted on and change patient outcomes. There's no reason we would restrict this to just pandemic-related diseases. Better use of pharmacy technicians. Obviously, with this group, that's where I want to spend a lot of the time here as we wrap up. That's where the huge opportunity lies. And then I think I've mentioned this, acting on the results and prioritizing testing when time and resources are limited. Right? Because anybody's pharmacy busy? Ever? I assume you're laughing because no, that's laughable. We have all the time in the world, right? When I talk to pharmacy CEOs, when I talk to pharmacists, when I talk to technicians, when I talk to anybody who's ever been in a pharmacy, in full disclosure, both of my parents are community pharmacists. I grew up in a community pharmacy. I know what it's like. I was working as a technician when the word pharmacy technician hadn't even been invented, right? You know, everybody's busy. Everybody has to prioritize what they can do, right? You can't do everything. So how are you going to make the best use of your time? So prioritizing testing when time and resources are limited. So let's talk a little bit about that opportunity for the pharmacy technician. You all know this, right? Pharmacists, this is like boilerplate 101. Everybody talks about the pharmacist is the most accessible healthcare provider, uniquely positioned, right? All of those things. There's an opportunity here, but it can't happen as a pharmacist-only run service. I will tell you flat out, the numbers don't work. If you have to pull your pharmacist out to do everything involved in point-of-care testing, it just isn't. It's not going to be an effective model. So pharmacy technicians need to play a larger role. If you intend to build a sustainable and impactful model of pharmacy-based testing, the pharmacist cannot run that by themselves. The technician has to play as large a role as they can in the regulatory environment. Generally, reimbursement, it's like for medications. It's like for everything, right? It covers at the lowest possible cost. So in order for this to be successful and sustainable, right, it has to be efficient. It has to operate at the lowest possible cost. So asking a pharmacist to spend 30 minutes or more conducting a service is just impractical in most settings. So the technician plays a key support role. And support role isn't even the right way to say this. Just a key role, a vital role in doing this. I will also tell you right now, are there any pharmacists in the room? Good. Pharmacists are no different than physicians, are no different than almost any other healthcare provider. They get a little territorial, right? They get a little bit of like, I need to do this, right? This is just, there is very little in point-of-care testing that has to be done by a pharmacist. There are a few things, but I will tell you 90% of it can be done by a technician. should be done by a technician. Probably will be done better by a technician. Again, right? This isn't being recorded, is it? Okay. Eesh. Well, there we go. I've enjoyed my job. So, some of this is probably consistent with the role you all play in your pharmacies today, right? In terms of paperwork and keeping logs and tracking things, right? So the roles of the technician to be a lab manager, right? So I talked about CLIA-waived laboratories, and you don't have to have any particular training. There are some paperwork requirements, right? There are some things you have to do. You have to track the tests you ran. You have to track the internal and external controls, and document that they were run, that you were followed. You have to make sure you have a copy of those manufacturer's instructions that you're required to keep. So somebody has to do that. There's no requirements on who, somebody. Certainly that could be a technician. I have been a big proponent of having patients walk in for testing. What we saw with COVID is that's just, that's not practical, right? You can't have 20 people congregating, standing on top of each other. So all of a sudden now there is probably some need for scheduling. And saying, you can, even if it's in 5-minute increments, as we saw at a lot of testing sites. So somebody to do that scheduling. Somebody to do patient intake. When somebody walks up and says, okay, I'm here to be tested. Okay, here's we need this information from you, whether it's your insurance information or some demographics or your whatever, your signs and symptoms. There's no magic in who hands somebody a clipboard or who asks somebody those questions. You can do the physical assessment. Have any of you ever done a blood pressure or taken a pulse? Or, if you've gone through Judy's program, I'm sure a lot of you have. There's nothing magic to it. It's a skill. You can be trained. There's no educational or requirements to do that. That's certain, less so with COVID, but for some of the other tests, taking a temperature or a blood pressure is an important part of that service. You all can collect specimens. I've taught my 18-year-old daughter, who's squeamish at anything, how to do a nasal pharyngeal swab. That's the one that goes way to the back. Right? There's no magic. There's no training requirements. You can do that. Operating the test itself, they are designed to be run by an untrained individual, right? So no requirements. Doesn't have to be the pharmacist. And then on the backside, the reporting to public health, reporting to a physician, faxing things, all roles that the pharmacy technician can play in supporting point-of-care testing in the pharmacy setting. And so I walk through a lot of these, so I won't necessarily go through them in great detail again. They have access to the slides. Judy, is that? Okay, so you can see this. Again, the key takeaway here, there are no federal barriers to this. There are some state barriers. They got relaxed during COVID. We need to keep moving forward and say that those are silly. Right? There is nothing about making sure you have the manufacturer's instructions in English that needs a PhD. Certainly as the volume increases, managing traffic flow and patient flow and having the right people in the right places at the right time becomes critical. Certainly something that could be done. When we talk about testing, with maybe the exception of COVID where it literally was pull up, we're going to test you, and we're going to send you the results. I don't anticipate that going forward. Going forward, it's going to be if you have these signs and symptoms, or if you were exposed, or if there is influenza in your community, or you have signs and symptoms, or you have a fever, or you have, right? A lot of things that improve the value of testing comes from physical assessment, collecting vital signs, all of which can be done by a technician. You probably heard a lot this year about the quality of the tests. Oh, you know, they lots of false positives, lots of false negatives, lots of... True, none of these tests are perfect, but a lot of those issues are user error. People weren't collecting good samples. Tests are better when people collect solid samples. And again, it's just a skill and a willingness to do it. So you should have a good understanding of the type of sample needed and how to collect it. I always tell people, as long as we're collecting things above the waist, I'm happy to be involved. Anything but, yeah, you're on your own, right? But anything, you know, anything head, neck, finger sticks can be done by a technician. Running the tests, pretty straightforward. The disease reporting, and again, it's just about attention to detail as much as anything, is being committed to reporting to the right person, using the right form, and providing the right information. So making sure the appropriate things are getting collected. Timely and accurate reporting is an important way for pharmacy technicians to be directly involved in public health activities, right? And certainly we're seeing that again with the Delta variant and the uptick, and how important it is to have timely reporting and sharing of information across practices and into public health entities. So I'm going to wrap it up and just say, you know, COVID-19 has impacted the regulatory and practice landscape for pharmacy-based point-of-care testing in ways I don't think any of us would have imagined, by reducing historic barriers. We're kind of, you know, you again, and I think I mentioned this, we're at that inflection point. We're at that moment where these changes could go either way. We could say no thanks, back away, let the door close slowly, and go back to the way things were. Or we can knock the door off its hinges and really change healthcare go forward. My hope, obviously, is that we do the latter. But that's going to require everybody, right? That's going to require pharmacy technicians and pharmacists and interns and everyone working together. The patients are ready. The patients want this. Now we have to go out and get everybody on board. And if the value has been demonstrated, if pharmacy stood together and said, we're going to continue to do this, the regulatory barriers go away because the value has been demonstrated. So I appreciate your time. I hope you have a great weekend. I looked at the agenda. Much, much better speakers tomorrow. Much, much better speakers tomorrow. But with that, I'd love a question or two, if there are any. Yeah?
So in your opinion, how far away do you think we are from this becoming a reality?
I mean, so I will say, you know, within the pharmacy space, everybody I talk to is planning to do COVID testing in the fall.
Okay.
I mean,
Well, I started the CLIA thing and then I kind of got frustrated, so I'm just wondering if it's worth my time.
it is. It is worth your time.
Okay.
I will help you. Let me know. I will.
The pharmacy, like the lab thing was kind of where I got confused. So I'm like, the lab manager, so that you cleared that up.
Yeah.
So.
Yeah. So there. Yeah. It's yes. Everybody is going to do COVID testing that I've talked to in the fall, and I will tell you, if you're doing COVID testing in a normal year, COVID and influenza look really similar, and so everybody's going to do flu testing too if they can get access. This will be the year when I think we will see pharmacy really rise to the top on this. He says, overly optimistically. But. Other questions? Yes?
How soon do you see other non-COVID, like the influenza or the diabetes and all of those, how soon do you see those coming out as well?
So they're out there. So I mean, there are, you know, I always talk like this is a new thing. How many of you have cholesterol screening machines in your pharmacy. Look on the top shelf covered in dust. They've been there for probably 30 years. So some of them are there. I will tell you, for me, for a chronic disease management, cholesterol, diabetes, it's harder to build a business case around because patients, you come in, you test my cholesterol, and you're like, hey, quit eating cheeseburgers. And I go, oh, but I really like cheeseburgers. But if I come in with an infectious disease like influenza where I feel cruddy, it's pretty easy for the patient to understand what you're doing. So the other good news, and go back 19 slides, with the reimbursement for COVID testing for Medicare, it includes reimbursement for influenza and RSV testing if done in conjunction with. So it's going to open things up. So I see that really taking off this year. Group A strep is, like every pharmacy that I've ever worked with that implements a strep testing program, if you market it well, it goes gangbusters. I don't know if any of you have kids and go back to school, and invariably they'll have strep throat, and so just get with a group of moms and let them know. You don't have to schedule a pediatrician appointment. They'll be like, I'm in on that. I will pay for that. So, again, it's getting it out there. It's having it where it is commonplace, where I don't have to seek it out. If I know my pharmacy does this, then that's when we're going to see the traction really take. All right. Any other questions? Otherwise, thank you all so much. Have a great evening. Hopefully the rain stays away and you don't get too wet. And have a good evening.
Thank you, Don.
Yeah.